All right, thanks everyone for coming to the March Probing the Literature. Today we're going to be talking about a topic kind of near and dear to my heart and many other hearts, I think, which is lung ultrasound, and especially pediatric lung ultrasound in detecting pneumonia. We're going to be focusing on it in a global health context. So what we're going to do is we're going to start, welcome our speaker, which actually I'll do a little bit afterwards, and then discuss the first article a little bit. The first article is a qualitative study, and I want to go into a little bit, not super in depth, but a little bit about what qualitative studies are, how they're done. And I think that it's a study type that we don't talk about much on this journal club, but it's something that's gaining interest among funders like the NIH in the setting of getting implementation science. And I think it's something that we could really use in our own kind of world of trying to get people to do and perform and document and communicate their ultrasound findings here and not just abroad. As much as possible, I would love for you to mute yourself, turn your camera on, and kind of identify yourself and your name in Zoom. The first article, Feasibility, Usability, and Acceptability of Pediatric Lung Ultrasound among Healthcare Providers and Caregivers for the Diagnosis of Childhood Pneumonia in Research-Constrained Studies. So as a background, pediatric pneumonia is a leading cause of death in children less than 5 years old worldwide. And as a result of this, the World Health Organization has something called the PMCID, or Integrated Management of Childhood Illness. And they specifically define pneumonia to be as sensitive as possible because they want to catch as many kids as possible because we know that these kids are dying at a pretty alarming rate. And so they define pneumonia as any kid with a cough or stridor actually, and fast breathing, which is age determined. And you can imagine that this encompasses a lot of kids, including kids that we here will call bronchiolitis most of the time. On top of that, there's a categorization for something called severe pneumonia, which is pneumonia plus kid looks bad, right? And the recommendation is generally, if you have a kid with cough and fast breathing, you start them on antibiotics, which in the IMCI is amoxicillin. And if they have severe pneumonia, you get them the heck to a hospital that can use IV antibiotics and potentially oxygen. So the study that we're going to discuss is actually a sub-study of a larger study performed by Dr. Ginsburg and colleagues a few years back, where they looked at the performance of lung ultrasound compared to this WHO definition and compared to chest X-ray. You can imagine that in the setting of such a sensitive diagnostic definition, people are really looking for a way to narrow this down to confirm the diagnosis of pneumonia. Chest X-ray is, of course, the kind of traditional way of doing this. And I think everyone in this group is pretty on board with using lung ultrasound for this purpose. But the evidence for it is kind of interesting, right? It's very location dependent, which is probably a function of training rather than the modality, right? So in Mozambique, these authors found that chest X-ray actually did detect quite a few pneumonias that lung ultrasound missed. Whereas in Pakistan, the majority of chest X-ray confirmed pneumonias were identified on lung ultrasound, and the lung ultrasound picks up a whole bunch more. In a systematic review and meta-analysis comparing chest X-ray to lung ultrasound versus kind of a combination clinical diagnosis, lung ultrasound just kind of does a little bit better than chest X-ray. And we know that in a lot of these environments, chest X-ray depends on having the patient go to another suite where the chest X-ray is performed or another clinic where the chest X-ray is performed, having somebody read the chest X-ray, having power to power your chest X-ray, which is a big problem, which compared to, a battery-powered ultrasound machine. On top of that study, the authors applied a consolidated framework for implementation research that's, I'll put up a slide a little bit for further kind of exploration of that, but essentially a way to think about, okay, you have something that you've shown evidence-wise works pretty well, and now you want people to adopt it in their clinical setting. And what does that take? And it turns out that that is something that takes a really long time, right? We know that that adoption timeline is something like 17 years, which is why the NIH is like, well, crap, we've put in so much money into like sequencing the human genome, but it's taking us decades to get that to the clinic. So how do we limit those barriers? And a big part of that is assessing your qualitatively what is going on in the environment that you're trying to apply it to. So generally what this involves is defining your stakeholders, developing a questionnaire, and having a very structured interview process that is then transcribed, coded using themes, and then analyzed. There are different ways of coding. There's something called inductive coding where you structure your interview and then you identify the themes and the responses, or deductive coding, which is where you already have some amount of codes and you predetermine what codes you want to use. And then you say, okay, like we're gonna look at feasibility, usability, and acceptability, apply little codes to that, and then determine what's going on. And the authors in this study used the deductive approach because they said, hey, like a lot of people have talked about what these barriers are. We want to see how much they contribute to them. The benefit, of course, is that you're like already have things pre-specified. The drawback and the benefit of an inductive coding approach is that you might miss something that you didn't know about, right? So what did they find? So overall, they had pretty positive responses, but I think a lot of the things they identified, in Pakistan and Mozambique, we probably have very similar problems and concerns, at my pediatric hospital at Dornbecker at OHSU. So the first is cost of repairs and equipment was a pretty big one, right? So like you can get a machine, maybe you can get a grant and get a machine, and Jessica will talk to us about that. But then what happens when it breaks? Right? And a lot of people had a lot of concerns about that. People wanted good administrator buy-in so that they didn't have to deal with those kinds of issues. And there was a variability between the Pakistan group and the Mozambique group in terms of people feeling that more or less training was required. And we kind of still don't know the answer to how much training is required. There was overall, people really liked it. They were like, yeah, I can find and look inside the people's body. Whenever you read these qualitative studies, I really recommend you look at the quotes, because that's the thing that's going to be like, oh, yeah, that totally resonates. Or you'll be like, well, no, like in my environment, this doesn't really apply. But there were certainly a lot of concerns about the time needed to perform the exam, because, you can imagine on the one side hand, you don't have to line everybody up for a chest x-ray. On the other hand, all of a sudden you can't see as many patients because you're doing a 24-point lung ultrasound. And there was a really interesting acceptability set of quotes from caregivers because they interviewed parents of children as well. And this exam takes longer than a chest x-ray. And so a kid who has fast breathing pneumonia is going to be crying for some of it. And some of the parents were like, well, I was worried the lung ultrasound was hurting them, right? So you really need to like address that in your community if you're going to make this an acceptable technology. So to talk about some of these issues, we have Dr. Jessica Schmidt, who's the Director of Emergency Medicine and Global Health, Associate Professor at the University of Wisconsin-Madison, and creator of the globalultrasound.com website. So I have a couple more resources, and I was hoping, Jessica, you could tell us about your experience with implementing ultrasound in a global health setting, and how some of these themes played into your path.
Great. Thank you guys so much. It's exciting to be here and to talk about global ultrasound. So for my own project, I've been working in Uganda for the past 5 years in a town called Mbale, which is on the eastern part of Uganda. And it's a regional referral hospital. And so essentially the catchment is huge. The catchment, I think, is 2 million people or something. And they have something like 17,000 admissions every year for sick pediatric children. And we implemented a project to train and evaluate pediatricians performing lung and actually cardiac ultrasound in the sick patient population. And the reason it's so crucial there is I should have brought pictures to demonstrate, but so in the HDU, which is the high dependency unit for these children, there will be multiple children to a bed, and they actually just got wall oxygen this last year. And so essentially, those big oxygen tanks like you have at a birthday party that fill up helium balloons, it'll be one of those, and then snaked out from that in an octopus fashion, there will be oxygen being administered to all the children. There's no portable X-ray machine, and even X-ray is limited by things like Nikolai mentioned, technicians, timing, renewable resources, things like that. Most children who are admitted for pneumonia at this regional referral hospital already had an X-ray before they were referred or never have an X-ray. And so part of the reason I think that ultrasound is very compelling in these limited resource environments is because it allows you to narrow that differential diagnosis so much instead of using something like this WHO guideline, which is great for sensitivity, but it's going to overtreat a lot of kids. The other thing from the literature is there's a ton of overlap showing that kids who come on, first of all kids cough, right? So they've shown that something like 3/4 of kids who present to any sort of acute care setting have a cough. That's just what kids do, kids cough. But then fast breathing is also a very nonspecific sign. And there's been a lot of literature that shows that the overlap between other disease pathologies, like for instance, malaria and pneumonia, is very common. So you have a kid who comes in with malaria is fast breathing, a kid who comes in with fever. And for those who've worked in these settings, you know that almost every kid is just going to get Rocephin and oxygen, and we're going to call it pneumonia, and we might be missing something else. And then we might be missing complications too, things like parapneumonic effusions or things that maybe should need ampicillin or should need other things in this pediatric population. And so that's why I think it's really valuable. So at our site, I got a grant from my university, from our Global Health Institute, that was a seed grant. And I worked with Fujifilm, which has the sound curing program. Essentially, if you partner with an NGO, which we did, you can buy a discounted refurbished machine. And so initially I bought a Sonosite, which was great because it's on a cart and doesn't walk off, but the whole site, and Nikolai's been there, is outside. You have to walk from place to place. It's raining a lot. There's a rainy season. There's really only a couple functioning outlets. And so I also budgeted things that the authors talk about in the paper, like extra money for batteries, for an extra battery. A big conversation was what to do when the machine breaks. And so we talked a lot about what to do when the machine broke. And then just now in this November, so 5 years later, the machine broke. And we had, there were some doctors who worked there from the UK, and they took the machine back to the UK, sent it to the Netherlands, and it ended up being $8,000 a service. And we weren't able to do that. And so we got alternative funders who donated butterflies. And then I also used my grant to buy a Lumify. So we still have machines, but there were some limitations there. Other big limitations were, another thing that the second article reflects on is continued maintenance of credentials and maintenance of kind of skills, and how do you do ongoing QA, and how do you do ongoing training? So with the Sonosite, we were using SonoClipShare with a USB, and they were uploading from the machine to SonoClipShare, and that's how we were assessing the images and giving feedback. And then we would like credential people and do an OSCE and then do ongoing QA. I think there's a lot of exciting things coming with these cloud-based applications, especially with the Butterfly. And Butterfly has been very generous in providing educational grants to our site in Mbale and also in Kampala for the whole medical education package where we can do QA. So we'll be able to do longitudinal QA. But I think that's another big part of kind of when we think about grants, it's not just going in and buying a machine and training some people. It's maintenance of those skills and ongoing.
Totally. Thank you. I wonder if you could talk to us a little bit about, you mentioned the site that you're at, but talking about how you chose that particular site. I think that's a big thing for many of us. Like, you start and you have an experience, and then you're trying to set up something longitudinally. And what was kind of the secret sauce to this particular site that helped you put it together and keep it going?
So there's always a lot of pieces of secret sauce. But I think one, you have to have those couple key people that are healthcare provider, boots on the ground people that are enthusiastic about ultrasound. But unfortunately, just like any training program, those people don't necessarily stay. So those people aren't going to be there forever. the big thing that I think has worked so successfully in our site is the administrative buy-in and support. And so we have the support of Dr. Peter Alapat, who heads the Mbale Clinical Research Institute. And he has been an amazing advocate for POCUS. Even I just got back this last month from doing a big training program where he allowed us to use his space at MICRE for free, get everything, gave me an administrative staff who coordinated everything for me for free, and then wrote it up in their university newspaper, really like promoting this, like this is going to make our university better. And so you have to have people who are ultrasound champions who will continue to do the ultrasound clinically and love it and teach it to their fellow healthcare providers. And then you have to have administrators who are willing to give you all the other things, coordinating for those clinicians to have time off, to attend your trainings, to have some sort of credentialing and support that's recognized by the local institution. Because without that, you're just going and you're being like, hey, University of Wisconsin taught you how to do lung ultrasound, so now you know lung ultrasound. That doesn't mean anything. What you need is Busatema University gave a training and developed a credentialing program, and Busatema University is going to credential my providers in Mbale in POCUS. And that's, I think, what really is effective. The other thing, how this partnership started is, again, I mentioned the NGO that we partner with. So we now are partnering with 2 NGOs because the other one gave us the butterflies, and they're both called Atlas, but they're different atlases. So one is Atlas International, and they've been working in Mbale forever and have University of Wisconsin ties, which is kind of through pediatrics, which is kind of how I got involved. And then the other is Atlas from a group in LA, and they really support donation of medical equipment to longitudinal programs that are doing what we're doing. So they're going to raise the money for the equipment, and then I'm going to go in and continue the training and things. But having those NGOs with the ongoing support, the ear of the people, sometimes, it's really hard even to set up a Zoom call with somebody in Mbale, because you have to get up at like 3 or 4 in the morning so that it's like their time. And then the Zoom connection doesn't work. And so then you try to switch to WhatsApp. And having like the NGOs on the ground who are having these regular meetings who you can have more of a conversation with and have a little bit more, I don't know, kind of like administrative oversight, I think can be really helpful. And it also helped with a lot of things like machine purchasing, getting letters to get it through customs, to get it in, to avoid import taxes, different things like that, that are sort of things that you don't maybe think about when you're going into it. And then just remembering things that I never thought about. Like one, like in Uganda, you have to engrave everything. If you don't engrave it, it walks off. And so, I mean, everything, even people's car windows are engraved, like anything of value is engraved. And then getting it insured, thinking about like how we're going to, who's going to own it. So those sort of things are all important to do kind of in a diplomatic way with somebody who knows the culture, because again, it's very, I think, American of us to be very informal and to go with our peers. Whereas I think working in a lot of other countries, it's a much more like you want to go to the person with the right authority, and that authority person is going to then kind of promote your project. And so you can burn bridges and kind of put your foot in your mouth if you undercut somebody on accident, thinking that you're doing the right thing.
Totally. Yeah. I mean, it's a lot of those kinds of things. I think it's a lot of the things too that maybe when I was a resident going into an ultrasound fellowship, I didn't realize how much admin stuff was involved. And then it's an even bigger kind of scale, right? Where you're like, now you're dealing with admin and local regulations and also a culture that is totally different. I wanted to do, I see some people that I recognize, but I want to do kind of an informal poll. If you have traveled outside of the US to teach ultrasound, there's a little reaction button. Can you give me a thumbs up? David looking for it. Teresa. Nice. Yeah. So a fair number. do you feel like, if maybe putting it in the chat, is it training, funding, or time that are your biggest barriers to kind of having a complete program? Typing, typing, typing. So kind of cultural barriers, Teresa, and in-country time. Jessica, can you tell us a little bit about how you set up in-country time to have some of that longitudinal presence? And I know that COVID was a big problem, but pretending that COVID didn't exist, what kinds of things have helped? And David, I know you're on too, and you have some thoughts. So if you're up to speak up, we're happy to hear from you too.
Yeah, so there's a lot of thoughts about going in and doing kind of a launch of a boot camp and then leaving. And so how we implemented our program, first we'd done a needs assessment, identified kind of the biggest areas that we wanted to address. So those were both clinical areas where we wanted to do some clinical management. And then also there was a big research interest. And so we had areas that we wanted to include in our research. So when we initially started, we taught, this is going to sound random, but it's, hearts and lungs, which to me is makes a lot of sense. We taught VTI, which is kind of advanced, what might think, because we were going to do some fluid challenging in sepsis work. And then we taught optic nerve sheath diameter, essentially because we wanted to evaluate kids with cerebral malaria. So we did an in-depth training, and then we had established a credentialing process where you had to do the training, attend the training, pass a test, and then complete 25 scans that were QA'd in each application, and then do an in-person OSCE, and then you were trained. But we understood that that's a lot of information. That's drinking from a fire hose of like all this stuff about ultrasound, because literally a lot of the people in our course, we spent the first time telling people, this is how you turn on the ultrasound. This is what a probe is. Like, it was very much like, after having done our needs assessment, most people had very limited experience with ultrasound at all. And so for a total of 10 weeks over the course of about 4 or 5 months, we had boots on the ground people, including Nikolai. And these were people who, as far as time and training, so these were a lot of my residents and fellows, because they're cheap and have more time. So they went and did hands-on training in the clinic with clinicians at the bedside to really reinforce those skills. It also broke down a lot of the barriers, because there's a lot of barriers since it's a new technology. People are nervous to touch the probe, especially in the training. People are nervous to touch the probe. And then having it be in the clinic, then I think were, a little bit more interested in asking questions and things like that. And then COVID hit, because I had this plan of like having, a zillion volunteers, and COVID hit, and that was a big bummer. So our research went on site, but our site visits didn't. And I definitely realized when I went back after COVID how much we'd lost, because you have a whole turnover, an entire resident cohort, essentially. So all of those people are gone. There was just a big, big change. That being said, now some of the people who I trained in my first training are the trainers. They've been doing individualized training, and they taught some of the courses for this last big training that we just did. So that's pretty amazing to see kind of that longitudinal presence that's continued. But my model essentially was, and it didn't pan out completely because of COVID, but the idea for the model was that you do kind of a boot camp just to get everybody kind of on board of, hey, this is what we could use ultrasound for, but then do a lot of hands-on repetition, just like in your intern rotation, in emergency medicine, where you get to do that hands-on with a guided expert, and then you pass an OSCE. And I really do think that that's kind of key. And one of the big things that I saw with my trainees is forcing them to be like, okay, you did this. Now what's the interpretation? Like there's a lot of hesitance to actually do the interpretation piece. And then the other hesitation, which we have with our residents here too, is integrate it into your clinical practice. Right? My residents right here are like laughing. But yeah, integrating it into clinical practice is definitely like, you know, the top of Miller's pyramid here. So that's where we're trying to get our learners, and having people on the ground that could be in the wards, you know, do pre-rounds with everybody, say, hey, maybe we should ultrasound this kid because maybe this kid doesn't have malaria, maybe they have pneumonia, you know, and then going back and actually doing it, I think is really, really important.
Yeah, totally. Well,
That's
thank
good.
you. Yeah, go ahead, David.
Okay, great having you guys present. Thank you for the discussion so far. I just want to clarify, I guess, my point more, which Jessica alluded to, that when you train someone on the ground and then have them become the instructor, which is, I think, the model that all of us strive for, right? That's the model of sustainability, right? Where you're doing knowledge transfer and then having them actually implement all this. The challenge that we've sort of experienced is, how do you actually protect that person's time when they have, you know, a lot of other competing interests? They're working multiple jobs. They are not just working at one academic institution, and they have other hats that they have to wear, right? And now we're transferring this new hat of being the instructor of point of care ultrasound. So obviously, I think it works when you have people that are very motivated, but is there another strategy that you've seen that maybe helps them achieve more protected time within their institution? Like, how do we have that skill set that they now have be valued more by their institution or by their clinical work where they're at?
What we're working forward in Bali is kind of working with administration to talking about it in Bali, and then also in Kampala at a larger level of really creating a fellowship following David's model, who they have this really amazing thing. So Peru is much farther along the path of emergency medicine. Emergency medicine has only existed in Uganda for about 4 years, which makes it very different. And the other thing too is, when you're establishing a fellowship, you have to kind of establish, well, what is POCUS? And so then you have to have the Ugandan Society of Radiology and the Ugandan Society of you know, all these people kind of decide, well, what does it mean? So I think that those conversations are starting, and there's really amazing leaders who are starting to have those conversations. I know from talking to people that there's a lot of motivation to develop a POCUS fellowship. But again, it should come internal. And I think when you get that internal time for a fellowship, then you get a lot more protected time as well.
Yeah, totally. That was the kind of the part in the qualitative study where people were like, no, admin needs to help us, because if admin doesn't buy in, then we don't have a time protected. We don't have, you know, that kind of commitment. I want to pause this discussion, and maybe, Andrew, we could just cut I think there will probably be a lot of interesting questions and comments at the end. So maybe we could do like 20 minutes to talk about the second study, which is kind of probably a familiar study design to most of us. It's kind of a diagnostic and a rate of reliability type of study that we've covered on this journal club several times. But I think what's interesting about it is the way that it is putting together this framework of large-scale field research around lung ultrasound and pneumonia. So this study is the protocol study of a much larger randomized control trial that was just published in the New England Journal in January, looking at pediatric pneumonia and how the type of stove you use when you cook affects your kid getting pneumonia. And they use lung ultrasound to define their primary endpoint, pneumonia, and we'll talk about how they kind of establish that protocol. I do have, Jessica, I have the picture of the octopus that you were talking about. So it was like this, you know, this oxygen tank going to an IV fluid bottle and then spreading out to all the children with pneumonia in Uganda. So, I'll stop sharing, and then we'll break out into small groups and talk about this next study.
There's a quick question. It looked like someone had raised their hand. I just want to make sure. It looks like, I think Teresa had put a question in the comment. The physicians are not the ones performing the ultrasound in the first article, correct? And then I assume that
Ye-
that's a question that, yeah, go ahead and answer that question.
Yeah, in the Mozambique, Pakistan article, they had folks that they trained kind of on the ground.
And honestly, task shifting is huge in low and middle income places. In our training session, we trained physicians and clinical officers who are the equivalent of APPs. But there's a lot of really great work. There's actually a study by Nudd and Polly et al. From MSF in South Sudan, where they just train like clinical officers to do pediatric lung POCUS with really good results.
And sorry, I think I misunderstood your question, Teresa. I meant like the Western trainers, but I think there was, in that qualitative study, there was a difference where the folks in Pakistan really felt like it should be clinicians performing the ultrasound. And then the folks in Mozambique were like, no, you could train anyone to do this. Like, yeah, we'll see the images and interpret them. So there's these regional differences. And I really like when you have like more than one site. You can imagine if we do a qualitative study at like our community site versus our academic site, our barriers are going to be totally different. And I think kind of exploring how that affects your barriers qualitatively becomes really important.
Yeah, I just meant that, I think I read that in some places the nurses are doing, the ultrasound, and I just want to, refer back to Dr. Schmidt when she was saying, like, when there's no defined emergency medicine as a discipline, you have to define what POCUS is, right? And I just remember hearing a Ukrainian physician who was telling me that in Ukraine, the parts of the hospitals that he trained at and worked at, there's actually an ultrasound physician sitting in the department, and so that is just such a different practice environment than what we think about and what we think POCUS is, because they essentially have an in-department radiologist that's just doing ultrasound. And so it's less of a question, more of like just kind of, like I say, a nod to acknowledge what you're saying, like even defining what POCUS is in different areas is so important.
Yeah,
That's
totally.
a great point.
Thank you.
So
Small groups?
yeah, I'll go ahead and pause the recording. Hopefully I'll get everyone into a small group. If it doesn't happen right away, it will shortly.